Good morning, everybody. Whilst we've got some people who are still getting coffee, and we know we've been joined by people who are watching this live as well, but it's always really nice to be in a real room with people. So thank you for being here this morning. Everything Everywhere All at Once is a 2022 Oscar-winning film, which you haven't seen, you should. It blends comedy, science fiction, family drama, serious inquiry, and absurdity, whilst the central character tries to connect alternative visions of themselves across a multiverse. I have no idea at all why we chose that as the title for our event. I have no idea at all, but you could reflect on that. Fit for the Future is an epic. There is a lot in it to welcome. A story about what the future lies, what the future could be, that for many of us is extremely recognisable, because there's lots and lots of policy ideas there that I've seen across the multiverse. A lot have failed. There have been a lot of difficult issues. And some of the trade-offs and the issues that need to be discussed in the family drama that is the NHS have often failed to happen. This plan, this 10-year plan, is without doubt an epic. At the heart, I'm told, is the voice of the patient, and at the centre of that is also the neighbourhood. This neighbourhood and the patient are enabled by AI, they've got money, the world is good. But everything everywhere all at once is exceptionally complicated. Sometimes that does feel absurd, sometimes that feels just like drama. But today let's discuss some of the areas and think about what really is possible. I would like to thank Optum for helping us make this a possibility. And I have to tell you that if there is a fire drill, you should go out the door you came in. So, without further ado, I will pass over to Sarah to chair the first panel.
Thanks so much, Thea. So welcome to the first session of the day. Why do NHS costs always rise? Just over a year ago, the public was told that the NHS had received the biggest increase in funding since 2010. But health systems across the country are battling to contain spending within budgets, and for many, getting access to the care they need is still a huge struggle. So where has all the money gone, and why does any extra seem to make so little difference? To discuss this, I'm joined by a great panel: Sally Gainsbury, Senior Policy Analyst at the Nuffield Trust; Ed Waller, Chief Strategy and Partnerships Officer for NHS Kent and Medway; and Dan Wellings, Senior Fellow at the King's Fund. Sally, would you kick us off by setting the scene with an assessment of the current state of play? We'll then have a discussion on the platform, and then there'll be plenty of time for your questions towards the end of the session. So start thinking about those.
Okay, hi, good morning. Oops, have I gone forwards? Well, there we go. Right, so just what everybody wants to start a Thursday morning with, a line chart. So where has all the money gone? The biggest increase since 2010. For really boring, nerdy reasons, this chart actually starts in 2011-12. Blame the Department of Health accountants for that, I think. So this is showing Department of Health's revenue spending since 2011-12 in real terms, going up to 28-29, which is the end of the current spending review period. Spot the global pandemic in the middle. So the point I want to make with this chart is that we are at the moment in the final quarter of what really looks like 2 decades of austerity. So a decade kicked off with the 2010 spending period with a real terms increase of about 2%. That was the coalition government. We then went to the SR 2015 with a much tighter settlement, which rounded off at 1.6% average real terms growth. We then obviously had the long-term plan period from 2019 onwards to the end of the last government. Those of you with good memories remember that the pledge for that was actually 3.4% real terms, so that applied to frontline NHS, which was a strange definition that didn't include not in the substantial trunk of Department of Health funding, so that averaged out at 3.2% real terms. And where the spending review earlier this year has left us is with a settlement that's looking at about 2.6%. Now, all of these figures have been adjusted to remove the impact of quite substantial changes in public sector pensions that came in 2019 and then another change in 2014. And obviously the figure going forward, the 2.6%, has some uncertainty about it, partly to do with inflation and also partly to do with how much income the Department of Health can realistically expect to receive from the immigration health surcharge, which has moved from a tiny little rounding error on, depending on how many decimal points you want to go, to actually about a whole % of the Department of Health's revenue spending at the moment, which is something my colleague Stelios, who's new to Nuffield Trust, has been looking at in some detail, so watch this space for some more analysis on that. So it could be worse than 2.6%, by the way, because it looks like immigration levels are likely to fall, and that could well translate into lower levels of immigration health surcharge for the Department of Health. Okay, so just to show you that really this is about 2 decades of austerity. So there you see the long-term trend. So at the moment we're smidgen under the medium-term trend, which works out about 2.4% real terms. And the chart that you're maybe used to us sort of talking to is where this leaves the NHS. About why are things so difficult? And one of the reasons things are so difficult in the NHS is that, of course, the spending trajectory that we're in the middle of 2 decades of really leaves us about 50 billion less money by the end of this spending review period than the NHS would have had spending increased in line with a long-term average. So this is the average since the late 1940s, which is a 3.7% real terms increase. So a 50 billion shortfall. Now, the bit we talk a little bit less about is the glass half full version of the story, which is the green line at the bottom here, shows what the budget would have increased by since 2011 had it simply grown in line with population growth adjusted for age, which leaves a gap of about 41 billion additional funding by the end of the spending review period, or about 33 billion this year, if spending had just risen in line with the age cohorts carrying on consuming as much healthcare as they had in the past, but the older cohort growing in line with how the older cohort has grown. So the OBR estimates that health spending grows in real terms by about 2.5 times the rate you would expect it to grow if it just grew in line with inflation. And so that's that's a trend that the UK shares with most other comparable countries as well. So the problem is the idea of 41 billion additional funding, is not the lived reality of most people working in the NHS, and probably not of patients either. So why is it that activity and spending has grown so much faster? So this is some work that colleagues over at the Health Foundation and the Strategy Unit did a few years ago, and they were looking at annual changes in activity rates. I've selected some of the most interesting areas, tend to be quite large spending areas, and so they compared growth and activity, so these are annual growth rates, by the way, over different periods, generally up to 17-18, and compared to what activity growth would be expected if they just rose in line with demographic change. It's kind of all round about the same, about 1%. Some procedures are more, you see more of them in younger age groups as opposed to older age groups. That's why those red bars, which is what you'd expect to change by, more or less are the same. But then we've got in the blue bar, you see the actual growth rate. So for elective procedures, that was over 9% growth rate. Now, of course, that's baseline to the 2000s. So some of that increase in activity will have been driven by the reforms of the new Labour government in the mid 2000s. But the point is that activity growth in these areas has far outstripped what we'd expect if we just grew in line with demographics. I think one of the interesting things to highlight here is emergency admissions. They've grown about twice the rate you'd expect with demographics, but it's a pretty modest excess growth rate compared to what we see on the elective side. Some of that care is also happening, as my colleagues have shown with a couple of pieces of work recently, in the last year of patients' life. So this is some really interesting work that colleagues led by Sarah Scobie did about 18 months ago now. They were actually set out to look at changes in healthcare that people received in the last month of their life before and after the pandemic. But one of the really interesting findings is this is outpatient appointments for patients in that last month of their life, and they're grouped by cause of death. And you can see that cancer outpatients, so in those last 30 to 31 days of their life, spent on average 2 of those days in an outpatient appointment. Those outpatient appointments, by the way, are not necessarily related to the cause of death, but we can expect that quite a lot of them will have been. Whether or not that was a good use of time, does this represent appropriate care for those patients, I think is an open question. So the government's 10-year plan, just look at time, it stopped timing me. Sorry. I'm getting towards the end of what I wanted to present. So the 10-year plan aims to possibly address some of the issues of these rising activity. So a big, with the care close to home agenda. So a big part of the care close to home agenda is about patient convenience, both people with multiple conditions, the idea being instead of being shunted from different hospital departments, another more convenient to access care in the neighbourhood. Possibly the area that would have more impact, or the hope would be for more impact on those at high activity rates is the idea that care close to home will introduce more preemptive care. So in very simplistic terms, reducing rates of illness by identifying illness earlier, possibly even before it's really manifest itself, and so slowing, bending that demand curve. And there's much less mention in the 10-year plan around what's more appropriate care, other than potentially sort of reducing emergency admissions, because particular reference around frail elderly groups. This isn't just about stopping them getting sick in the first place. Some emergency episodes might be unavoidable, but the idea in the 10-year plan is to address those through, for example, community response teams, and obviously also getting people out of hospital earlier, because nobody really wants to be stuck in hospital. I don't think there's any mention in the 10-year plan of the notion of realistic medicine. That's actually an idea that was discussed in a very small way in the 2023 Chief Medical Officer's report, but that would be addressing, for example, the level of acute care consumption in particular in the last year of people's life would be an obvious place for that to address. But there are real problems with the solutions offered in the 10-year plan, not least the prospect that preemptive care may, of course, actually drive up activity rates, identifying disease that perhaps may never have been manifest itself and therefore requiring treatment. We've got the question about how much duplication there might need to be, and the problem of if you build it, they will come, so supply-induced demand. Avoiding emergency admissions, I don't think anybody would dispute that it would be great if we could reduce the level of emergency admissions. So it's the right thing to do, but I think it's interesting to note that emergency admissions are possible in those areas which actually haven't grown as much. There's much bigger growth in elective procedures, so you question over how much scope there is to reduce those. And of course, the conversation around realistic medicine contrasts sharply with the government's emphasis at the moment on the importance to economic growth in its paradigm of the life science industry, and of course the news we had earlier this week that the NHS will be paying substantially higher prices for branded new medicines. So a kind of a shift for the NHS to prioritise innovation, partly in the name of economic growth over efficiency and health benefit. I think I was going to leave it there. I was. Can we move over to discussion?
Thanks so much, Sally. That's brilliant. Ed, could I turn to you? How do things look to you from the front line of an integrated care board? You know, you're grappling with these tight budgets at the same time as you're having to downsize quite drastically as an organisation. So what's the role of an ICB in these troubled times, and can better commissioning save us?
I think I have to believe the answer to that is yes. So, hello everybody, thanks for having me. I think the answer to your question is particularly pertinent in Kent and Medway. So, we are a system that overconsumes its share of NHS resources in receipt of quite a lot of deficit support funding, has some historic issues that we're working through, and is at the extreme of the paradigm people describe of overinvestment in the acute sector. So we spend more even than most systems in the acute sector in Kent and Medway. So what the 10-year plan describes about the left shift is even more difficult to deliver, but even more important to deliver. For me, the importance of the Commissioner's role starts with the clarity of the diagnosis of what is going on, the dynamic of the NHS system you're in. And in our system, it's about understanding where we are doing things, but we're not doing them as efficiently as we could do them. And there is always a good dose of that anywhere you look in any industry. And, you know, making sure that that is clearly identified and is tackled. Because my personal view is that that's where the NHS gets its authority in the discussion about the funding of the NHS if it can show that what it's doing is as efficient as it can be. Now, you're never going to get to a perfection, but as far as is humanly possible. The other thing the ICB can do, which none of the other organisations can do individually in the system, is look at the connection between the different parts of the health and care system and where the way the cogs turn and where they meet doesn't work. So in the dynamic that Sally described, the interface in Kent and Medway and everywhere else, and in the way people leave hospitals and get back to the community, back to their own home, is one of those examples. So on any given day in our system, you'll find hundreds of people who could be at home, who should be at home, but who aren't, and are sat in a much more expensive place. And at the front end, you'll find people who needn't have been in a hospital, but are in a hospital. And sometimes they're in a corridor in a hospital. And the connection between those two things, that the people who come in who don't need to be there often leave the hospital, not only having cost the NHS a lot of money, but also having had a relatively poor experience because they didn't want to be there, and often more dependent on the state and health and care services than when they went in. So there is quite a costly cycle from an ICB perspective, and a cycle that is creating an experience and outcomes issue. So you can see that from the ICB in a way that day-to-day on a ward or in a GP practice you might not be able to see. The same diagnostic you can see in day-to-day in general practice. So is, as I think it is in parts of our system, the problem with GP access a lack of GPs, if you go to Medway, for example? Or is it to do with the way practices are working and the optimal use of the resources they've got, which it always is in some places? And the diagnostic between those two things so you can actually resolve the problem as it's caused, I think is where the ICB plays its biggest role.
Fascinating. Perhaps we can explore that a bit further as the session goes on. But can I, for now, turn to you, Dan? You're in charge of the British Social Attitudes Survey, which, of course, every year is the most authoritative view of patient opinion about the NHS. So what do you think about this issue of rising demand, really exponentially rising demand that Sally's highlighted, far in excess of what demographic change would suggest? Is this about rising patient expectations, or is there a more nuanced reason for it, do you think?
Yeah, I mean, we look after the British Social Attitude Survey with the Nuffield Trust, and we'll be publishing that in the spring, so we'll get a sense of where we're going on that. But obviously, it was the lowest level of satisfaction ever recorded last year, so at 21%, and so much lower than anything we've ever seen in any previous period. But I think that question of rising expectations, you often see in documents, something says rising expectations. There's never a footnote. There's never any evidence around it. There's never any discussion of, it's just sort of said as a kind of article of faith that there's rising expectations. I think I would argue that expectations are going down. We've got a kind of experience-based realism about the NHS right now, which is that if you speak to people on a waiting list or people who are experiencing some of the admin issues, it's very hard to look at an NHS that you think your expectations are going up when the letter for your appointment is being sent to you after your appointment. When, if you're on a validation list, you may well be bounced off the list by a letter that you never received, and there's a dysfunction that's happening out there. So one of the things that we do see in this is that the public think that there is huge inefficiency in the NHS, and we can discuss that in terms of, is that right? I think if you are on the receipt of some of those things around admin, then you'd have to argue that it's very hard to argue that that isn't the case. There's clearly wastage around that, and people see it for themselves. I think there's a really interesting discussion around expectations of the NHS, expectations of our health now, and what we think we need to have good health, what we think about healthcare, and the range of where we then use healthcare. And that does seem to be changing. I think the one area where I think there is clearly, and it's Wes's announcement this morning, there's clearly a mismatch between expectations and what the NHS can provide is mental health. So particularly with younger generations, a colleague of mine in the audience, Chris Branson, and I have been doing some groups with young men recently, and you realise that for them, often it is mental health that is the key driver for potential usage of the NHS, and that they do feel that they're coming up short on that. So I think it's, in terms of our expectations rising, it's a far more nuanced conversation than yes or no. I think they're different in different sectors, different in different parts of our demographics, and I think that's the slight frustration on this. And I think in terms of the 10-year plan, it is also worth bearing in mind that we're so hardwired in terms of how we see the NHS and how we use the NHS. Driven by media portrayals, you don't see media programmes about moving to prevention. You see them about A&E and how we use services. And I think what I really welcomed was the public debate, or the work that informed the 10-year plan, the largest conversation ever held. I think we need to continue that. The results of that haven't been published yet. I think that cannot just be a one-off process. And also, are we speaking with double purpose here, where with the huge focus on waiting lists, we're not having that conversation about how do we start to have different expectations. And it was great listening to Ed there, because I was thinking that's really, some of this work to understand what people actually do needs to be done with users of services, needs to be done with patients, and working through that point you made around the fact that that is clearly very expensive. You hear the incredible, I heard a story the other day where young children who live in houses where there's mould are coming into A&E once a month for asthma and breathing related problems. So all you need to do is start with those stories and work backwards, and you would work very differently, but we don't. We start with the NHS and think about what it's doing, and that for me would be the big change if we started to have that different discussion.
Really interesting, the social determinants, essentially.
I think if you spoke to people in the way that Ed was describing there, you couldn't help but come back to the social determinants, because you would clearly realise what the biggest change to someone's life. We were at a food bank in Wigan the other day, and they were talking about on the nearby estate, people were buying takeaways on Klarna. And you just thought, where have you got to where you're buying poor food with money you don't have that drives you further into poverty? So listen to the story and then work back, and that relies on working differently in that way, about partners coming together to listen, not in splendid isolation.
I mean, Ed, you must be immensely aware of all these connections, you know, poor nutrition, poor housing, and how that plays into the people who turn up for help at your services. What's your thinking about the role of the social determinants and what you can do about that in perhaps bringing different parts of the system together beyond health?
Well, from an ICB perspective, I think what we're describing is the sort of underlying cause of health inequalities in people's health status. So I always think about the inequalities things, there being two components to it. The ICB can buy health services to try and reduce health inequalities, but in healthcare. But most of the underlying health inequalities are not caused or amenable to healthcare mitigation. So our relationships with our council colleagues and others are absolutely vital. Some of the places where the system doesn't work are a cause of public sector caused by public sector organisations, all in strain, trying to work at a boundary in good faith, knowing that they haven't quite got the resources they need to solve those underlying problems. So I think there is in our system, there is a shared understanding of what you need to do to deal with some of those underlying determinants of health. And the question is, how far as the NHS do you step into that when the demand that we're describing exists in the system? And how can you try and come to an agreement with your system partners about the right balance of those things?
Yes. Sort of what is the NHS for, ultimately? Do you have any thoughts about that?
Yeah, actually, I just wanted to come back on the expectations point, if that's okay.
Yes, of course.
And then I'll come to that one. Well, the expectation point, one at a time. There's a risk that we slightly use the wrong language. So there's the idea that activity is being driven by rising expectations. Really, rising expectations is there's not very many economists in the room, so I'm going to pick on them. It's kind of their shorthand for the gap between how much activity we'd expect to see and how much activity the much bigger actual activity number, and it's kind of attributed to this shorthand notion of rising expectations. But in that is high, technological advances that basically allow us to identify more disease and disorder and then treat it, and probably a bit of higher risk aversity as well. And so squaring that with the public actually potentially having a lower expectation. One of the expectations obviously relative to what you think the NHS should be capable of doing. So if you know you've got a lump, and a lump's been identified through a scan, you now have a legitimate expectation that is going to be seen to and diagnosed and biopsied, etc., etc. Whereas so these things kind of it's a messy business, and kind of so we wouldn't necessarily expect rising expectations, this sort of great big gap between activity and what we and sort of demographics to turn up in patient and public surveys with, yes, we've got really high expectations. It's on the question on social terms of health, I find it, it's really interesting, this question of what is the NHS actually allowed to spend its money on, and I'm most curious, is that even a conversation that you have? Because should the NHS, for example, be spending money addressing poor housing, so getting at the root rather than addressing the COPD that grows out of it? Do you actually are there kind of real legal limitations to what you're allowed to do, or is it rather that there isn't headroom in the budget anyway, so those conversations rarely come about?
I mean, in a system like ours, where we're currently in receipt of tens of millions, hundreds of millions even of additional money that is needed to support the financial position, in a world where the estate requires the capital investment that exists in the NHS part of the system to maintain it, and people have views about the state of NHS fabric. Making it, I mean, it's theoretically possible to make a bold decision, isn't it, to step out of doing that, to step into doing something else. But in order to do that, you would need to make a radical change to the level of NHS service on the treatment and healthcare side, inconsistent with the expectations of the NHS that the public have.
Yeah.
If we're talking about expectations, so I don't think the budget the NHS has anywhere allows the NHS to do both
Yeah.
in their totality.
I mean, on that point, Paul Corrigan made an interesting intervention earlier this week. He said there was a need for honesty to start a national conversation about what the NHS is for, by which I mean openly talking about what the NHS can and what it cannot do, in addition to what it should do and what it should not. Do we need to, I don't know what format it would take, but do governments and policymakers have to be honest enough to state the NHS can no longer do everything? I don't know who wants to go. Dan. Yes,
yeah.
So, I think, we look after the BSA, and I shouldn't really say this here, but surveys are part of the problem, because what surveys do is give you status quo bias, which is what people say they want. Now, they don't tell you where they could be. And there are some really good examples of people doing this work. So even on the 10-year plan, my understanding of the public engagement was that broadly the 10-year plan was focusing that debate on tertiary prevention or at best secondary. And it was the public that took the debate back into primary and to much broader. We can't just be there. And so people are far more reasonable than we sometimes give them credit for. And we did a piece of work, I remember doing a piece of work many years ago in Birmingham on cancer treatment. And it was really interesting. We presented people, we said, look, you've got the money, you've got the budget, and we presented them with treatment options. So we said there was like treatment A, which was like a Herceptin type drug at the time, treatment B, which again was a drug. We said then laparoscopic surgery or bowel cancer screening, what would you spend your money on? And people went for bowel cancer screening because they recognised that was the broader saving. But it's very difficult to do that when very loud voices are speaking around particular things. I think again, if you're trying to get votes, then it's very hard to not move away from access to primary care to deal with waiting lists and so on. So it takes a real element of bravery, and you can see this at the moment, I think, where you've got the 10-year plan, but you've got the real focus on waiting lists, and that is a primary target to be driven down. So that conversation isn't happening, but it is happening to some extent out there. There have been, in the groups that we've been doing recently, you can see people are having this debate around what it can and can't do. And I think in that Paul Corrigan calling it, I heard earlier, golden calf or a sacred cow, the NHS is very difficult to have this conversation about. The other thing I'd say, and I don't know, again, if we think back to 2010, when there was 70% of the public was satisfied with the running of the NHS, that figure looks more and more extraordinary with kind of every passing year, and it almost looks unattainable or unachievable. And do we look back at that period where finance was huge, and that has set some of our expectations around what is possible? So we're always trying to strive to get back there, and we haven't changed that debate. Is it possible? It's very hard to do, but it's going to have to happen. And if it doesn't happen explicitly, it's going to be happening implicitly by stealth, and that, I think, is where we're going.
And that would have real equity implications if different ICBs were making different decisions, as I'm sure they are to a large extent, Ed. But what would that sort of prioritisation debate look like for you on the front line?
Well, so we're beginning the planning round for next financial year now, and the conversations we are having are about how you allocate the money available to the NHS into next year between organisations. So, I mean, the truth of it is the things that you do in primary and community mental health care, they are much cheaper than what goes on in the acute sector. They're much less capital intensive generally. And they are, in some ways, you don't have to restrain the growth in acute sector demand very much in order to make a decent investment in primary and community care. That's the truth of it. I spent a bit of my career doing primary care, and the amount, what you can get for an investment in primary care in terms of capacity and outcomes is significant compared to what you get in the acute sector. So, but I think that the conversation we are having is how fast can you make that movement in a world where, as you're saying, we have a very long waiting list, and the demand that Sally describes is there in the system with an expectation that it will be dealt with in the way that we currently deal with it. So that it's that management of the pace of change conversation, really. I sometimes find the debate about whether the NHS should stop doing certain things quite unhelpful, because where it tends to go is a set of things which I won't list, but people in those conversations, people often name things which actually, in the scheme of what the NHS spends, are not the thing that is inflating the budget and the spend. It's not where the big growth is. It's not where the big money is. The big money is in, as I described earlier, the sort of elective and non-elective pathways in and out of hospital in the community. That's where the demographic challenge is. That's where we're spending the money, and that's where the big choice would be about doing it differently.
Yes, particularly the last year of life, I guess, is the most intensive period for spending on any patient.
Yes. So the last period of life, and a period where 5% of the Kent and Medway population falls into, we have a population stratification model, what we call patient need group 10 and 11, which are the frail, quite often older population. There's another 2% that are in care homes. Those people spend a lot of time in contact with health and social care services. That's where we spend a lot of our money. They constitute nearly 30% of our admissions into hospital. They stay longer than other people. There's a big debate about how we provide what's actually right for those people.
Yes.
I'm not sure we actually succeed in providing what they really want either a lot of the time as a system.
Which would in general be remaining at home with support, presumably, certainly not dying in hospital, as I think still the majority of people do.
Exactly.
Yes.
Yeah.
Sally, I was interested in your point about preemptive care and how that may actually increase demand. It's not necessarily going to reduce it, particularly with the need for kind of double running of services before the full impact of moving care into the community can sort of realise its savings, if there are savings. What are your thoughts around all that?
Yeah, I mean, that kind of view needs to be sort of modelled and explored a bit further. It's a kind of certainly it's not an outlying hypothesis. It's not to be concerned that preemptive care might may well end up increasing demand. I think in terms of how it's presented in the 10-year plan, the equity question comes in there as well, actually, because if you remember, a fair chunk of the 10-year plan was discussing kind of preemptive care in otherwise well population groups, and made the point that these population groups, the better off in those groups, are already accessing preemptive care. The kind of the biohackers and the wearables and off-the-shelf blood tests, even though these are not particularly accurate or helpful. And I think there is some early evidence actually that privately available testing is actually increasing demand on primary care. There's some work in BMJ a few months ago on that. But I think this issue around what's inside the NHS, what's outside the NHS is one of the is possibly the reason why politicians are very reluctant to address because it's kind of this sort of Pandora's box of equity. If there's a question about limiting what's available in the NHS, so then we go back to this kind of concern that, well, why should some people be able to access a higher level of care, have higher levels of reassurance, for example? Well, can we just go and check this lump? Can we just whereas the NHS pathway might say no, we don't check those lumps in people over this age. So I keep talking about lumps, but so I think that's and that's a genuine concern, because up until now we've kind of had this idea the NHS is it's pretty comprehensive in what it provides, and if it shrinks down, then there will be a substantial chunk of the population who won't be able to access that additional reassurance, and another chunk that will. And I think the challenge to that is, so that's the sort of Pandora's box, but to mix a metaphor, the genie's already out of the bottle in terms of accessing private care. We've seen with the pandemic a huge growth in people accessing elective care in particular, and to some extent primary care. So how realistic it is, whether or not we just kind of really just need to tackle these issues anyway. They're really difficult and complex. So.
To get it, and I mean, as you rightly say, there has been this growing flight to the private sector, which actually isn't by any means limited just to the middle class, I don't think. I saw some interesting data suggesting sort of DE socioeconomic classes were were actually occasionally using private healthcare, perhaps for a GP appointment or the like. But what do you think the implications of that are, Dan, for support, broad support for the NHS, and particularly the principle of taxpayer funding?
So I would say on that I know the Nuffield Trust does a lot of work on this, but dentistry is such an interesting example to look at how changing attitudes are formed there. So again, some groups that we've done recently where people have just realised that the NHS dentistry hasn't really existed for them anymore and it doesn't work for them. And so they're starting to take out private insurance or starting to look at different models for how they access dentistry. And so that's a really interesting question for what does that do in terms of, is that the bit where you start there and then it becomes, the other group, we did a group recently where for the first time in a long time, or ever, I think, I've heard people talking about their private GP and their NHS GP and almost working on a sort of slightly more market-based, where do I go for different things when I need them and how do I get around that? Having said that, on the principles of the NHS, they've largely been rock solid. I say largely because two are dropping. One is comprehensive and available to all, which I suspect is the debate on immigration and who the NHS is for, and that is particularly pronounced around reform voters that we're seeing that is dropping off.
This is support for it remaining a comprehensive
so support for, so does it definitely apply or probably apply? We've seen changes on that over the last couple of years. A quite pronounced change last year. Still overriding rock solid support, but you're starting to see some changes in that. I think on the primarily funded through taxation, again, that is still rock solid support, but incrementally over 4 years, we are starting to see a drop on that. Now, we'll see when we get the results for this year, whether that was the start of a trend, whether that trend will continue, whether it's because of, it's at a very, working hypothesis, if satisfaction falls, does your desire to pay for it drop off because it's not working for you? So these are, I think, very live questions. The one thing I would also just say, we talk about national conversations and big public debates, and I've worked in this on social care for so many years now, and we always talk about a national conversation or a big public debate, and it just never happens. So we looked at the Ipsos Issues Index in August this year. 3 people out of 1,000 said it was the most important issue. 13 said it was one of their most important issues. So what would you do to try and change the public? You would try and get them to think about social care as well. And I think there's a big debate to be had in the social care sector about how you do that. Because unfortunately, and this is not palatable for the social care sector often, if you associate social care with the NHS, support drives up for doing more with it. That is not something that social care always likes to talk about or think about, but that for me is it isn't the NHS. The NHS is the service that's still open for people where many other services are shut. And that, I think, is a really interesting question on demand, which is how do you have that conversation about these are some of the reasons. You speak to some GPs in certain areas, they essentially think they're not, 50% of their work is nothing to do with NHS work anymore. It's to do with all of the other things that they face day to day.
Yes. Any thoughts, Ed? Anything you wanted to contribute there?
I mean, it's definitely true that a lot of the work in primary care, if you talk to our local GPs, they will say, and anywhere, a lot of the patients that come through the doors of primary care may have a medical need, but it's also often secondary to the things that they want to talk about their living circumstances and their other things in their life, and that there's a mixed up relationship between all of those things. But the GP is there and open and available, I agree.
What about this issue of more and more patients mixing and matching with the private sector? Is that something you would welcome to a degree, because it would ease some of your pressures, or how do you sort of view?
I mean, the way I would describe it is that a lot of the people who live in Kent and Medway, the majority of them, don't have that choice. They just simply don't have that choice, and I think those of us who work in the NHS would want it to be a service where that wasn't necessary. So that's where we'd start.
Yes.
People are obviously free to make their own choices.
Of course. I mean, the generational aspect is quite interesting here, isn't it, Dan? That there are some signs, at least anecdotally, and I think in the data to some extent, that the sort of under 35s are increasingly looking to the private sector for, perhaps, fortunately, at that age, few people need much healthcare. But I think you're starting to see, aren't you, in the sort of nitty-gritty of your data, that there is a significant difference in view between, people in their 20s and 30s and others.
Yeah, it's very difficult to know whether it's a life stage or a cohort effect. You do see that, particularly with the younger generation. We're seeing it in the primarily funded through taxation question on the BSA, that Generation Z is less likely to say that. Now, that is cost of living crisis, is all the other things that are going along with that. It doesn't mean that they're not. It's a different question. And I think, as I said, the other thing that's really important is what we said about earlier about mental health.
Yes.
And what different groups in society think they need from services. And I think that's underexplored. I think that's a piece of work that really, really needs doing. So we're starting to see some signs there. It feels more anecdotal than absolute evidence-driven, but I think it's a really important piece of work to do, particularly if you're thinking about what that social contract looks like and where a younger generation is coming through on that.
Yes, fantastic. Can I turn to the audience? Does anybody have a question for our panel? Yes, lady here. Just yes. There is a mic, I think. Yes.
Hi, I'm Tanya Greenland. I'm at NHS England strategy lead for mental health, learning disability and autism, but previously at SLAM for about 20 years running mental health services. But my question is, what does the panel think about what could potentially be a double-edged sword with private sector usage? So we see some people going abroad, for example, going to get certain procedures and then coming back into an NHS system for follow-ups, etc. So a question about whether it's time to have a good look at what the spend is when people choose to spend, I'm going to use a ratio, £1 in the private sector, but actually the backwash into NHS in aftercare, because complexity, things going wrong. And so that's for things like cosmetic surgery. But also we see that in terms of mental health, where people might go to a diagnostic private provider for an autism diagnosis, not happy with the outcome, or if it's ADHD, they'll need the prescribing picked up by NHS. So I think it's a double-edged sword. I think, yes, you might opt to take the resource and use private, and there's a win in immediacy, but the ongoing issues are complex, I think. Be interested in what the panel thinks.
Yes, with a real equity dimension to them, as you highlighted, Sally.
Yeah.
But would you like to respond to?
No, I agree. It's a really interesting area. What we don't know, we can't quantify it at the moment. If someone would like to commission the Nuffield Trust to do some research on this, we would love to really dig into that. Because I think there's real dilemmas as well for clinicians. So if you know someone's sought a diagnosis in the private sector and now they can bring that urgent diagnosis to you, but that there's, that's one of the reasons why, politicians have, why we have kind of, diagnostic waiting time targets, I guess, to sort of avoid that dilemma. But I think there's a lot of really interesting, tricky issues, and we would love to look at them. Anyone got any answers
from the
though,
other? Yes.
Well, just that we do it with you. I mean, no, I think it's really interesting. It's and I think there's also
a great idea for any commissioners.
This is how we do it, is it?
Yeah.
So I think it's really interesting. Just also, I'd say the other factor is obviously just the kind of globalisation and the use of the internet. It's just changing so rapidly, and we're not keeping up. So we don't know the answers to many of these questions. To be honest, I think you're right. The ADHD and autism, particularly in young people, is where you're seeing that playing out. And it's so emergent that we don't know the answers to some of those questions. But I would come back to what Ed said around the inequality, come back to that food bank and the Klarna example. That is not an option, So what do we want it to look like?
Great. More questions? Yes. Variety to choose from.
Hi, Chris Branson, consultant with Whitehall, also working with Dan on the mental health work, associate with King's One. I wanted to ask about the role of technology in rising costs, so pharma, medtech, AI and data, very often introduced as a solution for savings, productivity and so on. I was curious, Sally, is there any sort of historical evidence that technology ever leads to a decrease in spend in health? And then from an expectations point of view, what should the public expect from new medication, new technologies? You know, is that a part of the conversation that needs to happen going forward?
Who wants to start with that? Ed, from your front lines?
Well, I mean, I think it must be a mixture of all of what you're describing, mustn't it? So there are some technologies that are cost additive to the NHS offer, very clearly, but are providing lots of outcome improvements for patients as well. And there is a debate about, you know, how far you want to go, how much you're willing to spend on that outcome improvement. That is some of what that rise in NHS spending over the last few decades has been. It's been improving people's life expectancy and quality of life by offering new technology and treatments to them. Not all of it saves money, I agree. Though if you know, there are places where you can, I think, find examples of, you know, vaccination programs and other things that probably have. There are very clear examples, I think, of technology to administer the NHS that has saved money. You know, what people have done with things like their HR functions, finance functions. And I guess I would argue, if some of the technology available in the sort of middle office doesn't save money, it wouldn't be so widely used in the industries outside of healthcare. So I think there is a big opportunity for us to think about how we bring some of that into the NHS more quickly than we're managing. Some of what Dan was describing earlier in terms of the way we administer the system and whether we can improve that. Hence the push for technology and the app and things in the 10-year plan, I think.
In terms of the outcomes that patients get from new technologies, I mean, you know, we can't ignore the announcement earlier this week about, you know, the NICE threshold that, you know, and also coupled together with the announcement, I think it was in the 10-year plan or maybe it was in the Life Science Review, but medtech will now be increasingly assessed underneath the same criteria as new medicines, and this increase in the threshold does mean that those outcomes for new technologies, medicine or devices will, you know, the kind of the threshold is around about 3 times the cost that it currently costs the NHS to produce a QALY, so to produce, let's roughly call it an outcome. So there is, you know, yes, there are outcomes for patients that individual patients will value and are important for those patients, but on a population basis, it is offsetting more benefit than we would get if that spend was just spent on expanding GP services, elective care, even though we've, you know, slightly problematized the growth in elective care.
Right, thank you. Should we move on to another question? We've got quite a lot.
Thank you. I'm Tim Jobson from Somerset. I'm a secondary care clinician, but also with a role in prevention as well. I just wonder what the panel's view is on productivity, particularly in secondary care. I've got a view. I work in secondary care. My view is it's not where it should be in terms of productivity, and secondary care is a money sink. And as Ed said, there's much more bang for your buck if you get that resource into primary care, particularly in terms of prevention. But my view is anecdotal. What do the data actually tell us about productivity?
Sally, do you want to start?
Well, NHS England's data says that acute sector productivity has been improving over the last couple of years, but they measure the output on the cost of the output rather than the value of that output to the patient. And to be fair, Penny Dash at NHS England has made the point that, you know, this isn't ideal, and they should be measuring it on, you know, something that's more meaningful to patients, like a quality adjusted life year. You know, that's incredibly complicated to do. But in terms of, you know, the widgets at the end that acute hospitals are producing, they are, you know, they're producing more than they were 3 years ago, relative to the inputs that are going in. So there is improvements, but whether or not those improvements are the things that are important to the population, I think that's over to Dan in terms of like the public views.
Do you have
That's
a
my cue.
Dan? Yes, sorry. Yes,
Yeah.
go for it.
I didn't hear the question fully, so if it's about the productivity, could you just mind just summarising it?
We can't hear very well
Couldn't
because
hear
the
very well.
thingies are pointing outwards.
Yes.
Do you want me to come in while you think as well?
Well,
Yes.
As I work in secondary care, productivity seems a lot less than it was 20 years ago.
okay.
But that's an anecdotal
So I think just back to that kind of what people see from, I think is a really important question in terms of efficiency. So there's a perception as well as what the reality says. And I come back to the work we've done on admin, where people just see what they see as a very dysfunctional system. Having said that, I think the inpatient survey this year is really interesting. So people think there's more staff on wards. They feel better with the number of staff that are on wards at the moment. And there's an increase in overall experience in the inpatient survey. As there is in the GP patient survey, there are some signs. I mean, it's really important to bear in mind that the British Social Attitude Survey is with the public. It's not an experience survey. It's citizens, taxpayers, voters, and experience, and lots of things are factoring into that. All I can say in terms of the experience surveys is we're starting to see some signs of improvement, particularly on the inpatient survey. Now, it's not back to where it was pre-COVID, but we are starting to see those signs of improvement. So that's all I'd add in terms of the staff numbers. It looks like it's being noticed, and it looks like it's having an effect on overall experience.
Which is the important bit, because staff numbers increasing on their own is bad for productivity.
Can I add something from a commissioner's perspective? So I think the answer to your question is that you should never look at productivity metrics on their own. So it's possible to be super productive delivering things that you shouldn't be doing. So the most obvious example would be you can run a very productive outpatient clinic where you see lots of people for a follow-up that never needed to be there, but they're very quick and they all count. So the important thing is to make sure you're doing the right activity. When you're doing the right activity, then comparative productivity measurement is quite important, because it matters if one hospital can do twice as many knee operations on a list as another, because it indicates something about how well it's working. But the thing you've then got to triangulate it with is the outcome of all of that work. So it's also not a good thing if you do lots of knee operations, all of which have a terrible readmission and outcomes profile. So if you look at things too simplistically, I think you fall into a trap.
Yes. Or you do lots of cataracts. Your private sector providers.
I think we've got time for perhaps one more question. Sorry, we're...
Hi, my name is Nancy. I'm a public health doctor and also a clinician working in Nuffield Trust. I'd like to build on what Ed just mentioned here. How can we swap NHS lenses from being so activity-driven to outcome-driven? Because as Ed mentioned, I go to a lot of outpatient boards and you see all these beautiful dashboards, but they're not really measuring how many patients are coming back or how many patients has had like a failed service and they're not happy about the service that received. So how can the NHS focus more on outcome that are meaningful to patients? And I feel value-based healthcare is a very important topic that we should raise more within the system. What delivers value to patient? So as we get more and more busy with our activity, it doesn't really mean that patients are getting what they want, and that's why they keep coming back to us. And we might be very productive, but they're not happy.
Thank you. Really important question. Who'd like to take that down?
Yeah, it's a really interesting, I think that whole working with, is such an interesting question. So if you look at what's happening on the MSK pathway in Sussex, so they took, I think, 500 or 1,000 people off the waiting list, and they had a very different conversation with them. It wasn't, are you happy, what's satisfied? They just said, tell me about yourself. Tell me about your life, tell me about your family, your community, what works for you. And then they worked through with the voluntary sector and with all the partners that exist within a local system what was best for that individual. And they took 50% of people off the waiting list. And there was very few that came back on. And they had a really interesting example they gave where there was one man in particular they worked with who used to do lots of exercise, and they said to him, why have you stopped? And he said, well, the person I did it with has died, I don't have anyone to do it with, I'm on my own, I live, da-da. And the answer for that person wasn't keep them on the list in the wrong queue for the wrong thing. But it's a very different way of working. It's a way of working that I think you have to start doing, because that is the fix, as it were. And actually, the cost for that person was then to go to a community group where they would do their exercise, and there was different things. And if you realise that health is generated beyond, the biggest conversation you want to have is, you do realise only 20% of our health is determined by the thing that we love, or the golden calf, or whatever it might be. And you have different conversations with people. But that will make you work differently. But you have to go and do them. You can't exist in the NHS bubble. You have to move beyond it. So that would be my answer to that question.
really interesting. I'm sorry, the fellow panellists would probably like to come in, but can I just ask each of you a final question? If you had to cast your minds forward 5 years, what's the most likely scenario we will be facing with the NHS as it struggles with these ever-rising costs and expectations that we've been talking about for the last hour? You know, will there be some form of sort of organised restriction in the NHS offer, or will it be death by 1,000 cuts, or somewhere in between? I don't know who wants to be brave enough to start on that one.
You should go first.
Well, I think I would say that where the NHS goes next is in our hands. So I worked at the centre of the NHS for a while, and one of the things you realise when you work at the centre of the NHS is that you have a very significant opportunity if you have a medium-term clarity on direction and a medium-term clarity on the finances and a medium-term clarity about the expectations. And we do have those things. We know what our budgets are for 3 years. We know what our capital budgets are for 4 years. We know what we're expected to deliver in performance terms. I think that does allow you to make the nature of decisions that you don't make if you do year-to-year. If you do year-to-year planning rounds where you start thinking about it at Christmas and you run into the next year, there is a lot of inertia in the NHS, a lot of inertia in the world, but there's a lot of inertia in the NHS to carry on doing it as it's done. So I would say we are at a point where, it's a politician's answer, isn't it? We're at a point where it's in our hands what the outcome is now, and we've got to be a bit bold about the things we decide to do with the clarity we've got.
Thanks very much. Sally?
Yeah, I'm toying between agreeing with Ed in terms of like there is, you know, the kind of the medium term messaging around the money is much firmer than it has been in recent years, and will that mean that, you know, the NHS will live within its existing envelope? And you're thinking back to what's happened over the last sort of 15 years, which is that we have kind of a fiscal event in the NHS every 6 months, and the budget changes, and so I'm uncertain. Yeah, I'm uncertain whether or not that, you know, for example, I can't remember what I said it was now, 2.6% in real terms, that we're left with the spending review period, whether that will stick or it will have to just increase because that's what's happened in the past. I do think, given what we might expect to happen in the next general election, is that there will be a debate around, you know, tax rebates for people who pay to go into the private sector, for example, which, you know, will be, you know, another challenge to the kind of the funding model. But I don't have a crystal ball to predict what the outcome of that debate would be, or it will just be kind of a lot of noise and not much change.
Thanks, Sally. Dan, finally.
Yeah, I don't think we would have had the national conversations that we talked about. I think that doesn't really happen. I really hope we do. I really hope there's traction on social care is the answer I'd give, because that feels like we just forget. We just don't talk about it in the way that we need to. So I think, you know, there's also, I'm minded of what Amanda Pritchard and colleagues said about the 5-year recovery from COVID. I don't think we talk about it very much. And those signs in the inpatient survey and the GP patient survey, I really hope they continue. And we don't talk about what that, it's an odd subject that we don't really come back to, which is, I think, that Amanda and colleagues, may include you, Ed, were right. And we will start to see some signs. Whether we've had any of these big debates, I am less hopeful.
Well, thank you so much. I'm sorry we've overrun a little, but I think it was worth it. I hope you'll join me in thanking our panel for a wonderful discussion.